Dr. Pooja, we have all the panelists from your end. We've created them as panelists, so we'll begin whenever you ask us to. We have 43 attendees joining us by now. We are good to start, Dr. Pooja, whenever you are ready.
Yes, ma'am. We can start now.
A very warm good afternoon to you all, the distinguished panelists, our speaker, and also all the participants who are joining us today. On behalf of the Institute of Liver and Biliary Sciences and the Empathy Campaign, I welcome you all. I am Dr. Namrata Mohan. I serve as the project officer with the Empathy Campaign, and it brings me immense pleasure to once again associate with the Manav Rachna Dental College. Our association goes back to 2018, and today we are together again to host the second webinar in series of the webinars in recent advances in prevention and control of hepatitis B and C. I proudly present the co-host for the day, Manav Rachna Dental College. And before we begin formally, just a brief housekeeping for you all to follow. The audiences have been put on mute by default. So for the convenience of the webinar, all our panelists have access to the chat box and the videos. I request the audiences to please drop in your queries at any point of the session whenever you have any inconvenience and you would like our assistance. Please find the question and answer box in the control panel of your Zoom platform. You may drop your questions and our team will best try to answer your queries and troubleshoot any problems that you're having during the sessions. Although for the queries related to the sessions, we will have some time at the end of the session during the plenary session during the panel discussion. So please find the question and answer box in your control panel or your Zoom platform and dropping your queries for our team to assist and troubleshoot your problems in case you're having any during the sessions. So I now open the platform, and before we formally begin once again, there is a link that has been posted in your chat box requesting all the attendees to please take a moment to fill in the survey. It will lead you to a brief question and answers, brief questionnaire that we expect you to fill in, submit all your details, and there'll be another post-webinar survey that would follow the session towards the end, towards the conclusion of the webinar. We require you to fill in both the surveys and submit them positively for you to enable the e-certificate link, which shall be delivered in your emails. Once again, the link has been posted in your chat box. Alternatively, the link is being displayed on your screens as well. Please scan the QR code, which will lead you to the questionnaires. Take a minute to fill in those questions for us and positively submit it. I now hand over the time to Dr. Junam Nishi Burman to formally begin the webinar. Dr. Junam, please.
Thank you so much, ma'am. Good afternoon, everyone. To one and all present for this webinar, I, Dr. Junam Nishi Burman, Department of Periodontology, MRDC, welcome you all to the National Webinar on Prevention and Control of Hepatitis B and C, organized by Department of Periodontology, MRDC, in collaboration with Institute of Liver and Biliary Sciences, New Delhi. To brief a few lines about hepatitis B. So viral hepatitis, it has become a silent epidemic worldwide, and India has intermediate endemicity of hepatitis virus. According to the data provided by WHO in Global Progress Report on Viral Hepatitis 2021, 1.5 million people were infected with hepatitis B virus and 8,20,000 deaths were reported due to hepatitis B virus. Pervasive increase in serious transmissible diseases over past decades have created global concern and affected treatment approach of all healthcare professionals. There is an increased incidence of hepatitis B virus among dentists, dental staff, and students. And it was noted that overall awareness among dental students is only fairly satisfying, which signifies the need for continued infection control education among students. So without further ado, I would like to invite Dr. Pooja Palwankar, Dean PG Studies, Professor and Head, Department of Periodontology, MRDC, to welcome the guest speakers. Over to you, ma'am.
Thank you, Dr. Junna. We extend a warm welcome to all esteemed speakers on this platform. The speakers for today are as follows: Dr. Kanika Kaushal, Assistant Professor ILBS, Dr. Tushar Prabhakar, Senior Resident ILBS, Dr. Shakila Mahesh, Head of the Department Microbiology MRDC, Dr. Rahul Gehlot, Project Officer Empathy ILBS, Dr. S.K. Sareen, Vice Chancellor ILBS. This webinar is jointly organized by the Institute of Liver and Biliary Sciences, New Delhi, and Manav Rachna Dental College, Faridabad. The topic for today is recent advances in prevention and control of hepatitis B and C. The knowledge of hepatitis B and C is essential for dental surgeons as it is categorized as a high-risk profession. We, dental surgeons, get exposed to oral fluids and blood on routine basis. Thus, the objective of this webinar is to sensitize the dental school undergraduates, postgraduates, and faculty members about the screening, vaccination schedule, providing health education for HBV and HCV, and providing post-exposure prophylaxis algorithm. Thank you.
Thank you so much, ma'am. So moving on with the first speaker for today, we have Dr. Kanika Kaushal, who will be discussing burden of hepatitis B virus and hepatitis C virus in India. Dr. Kanika Kaushal is an assistant professor of epidemiology before recently joining ILBS in October 2021. She has worked as technical officer at South Asia Field Epidemiology and Technologically Network, Safety Net, an international organization funded by United States Centers for Disease Control and Prevention, Atlanta, US, for India Epidemic Intelligence Service Program. She managed the India EIS program for National Center for Disease Control, Delhi, and worked actively in various COVID-19 related outbreak investigations and surveillance activities since March 2020. Before joining SafetyNet, she has worked in the digital health space during her tenure at PGIMR Chandigarh, where the team successfully helped set up electronic health records in a public health dispensary from scratch in collaboration with HISP India for outpatient services to the slum population of Chandigarh. She also implemented smart technology in a small village of district Panchkula, Haryana, where they checked the feasibility and utilization of mobile phone-based smart technology for chronic hypertensive and diabetic patients in a resource-constrained setting at a rural care post in North India. She has also published over 50 research articles in various national and international journals. Over to you, ma'am.
Thank you, Dr. Junam. I am Dr. Kanika and I'm working as assistant professor here for past 4 or 5 months. So today I've been given this opportunity to share with you the current disease burden in India for hepatitis B and C. So as you all know, there are 5 types of hepatitis that we know of: A, B, C, D, and E. So just 2 slides on A and E. So viral hepatitis is increasingly being recognized as a public health problem in India, and hepatitis A and E are important causes of acute viral hepatitis and acute liver failure. But due to paucity of data for A and E, the exact burden of disease for the country is not yet established. However, available literature indicates a wide range for A and E, and that causes acute hepatitis or acute liver failure cases in India. So 10 to 30% of acute hepatitis cases are because of hepatitis A, and 10 to 40 in hepatitis E. And similarly, for acute liver failure, 5 to 15% of the acute liver failure cases in India we owe to Hep A virus, and 15 to 45% of ALF cases in India we owe to hepatitis E virus. So these are because of the bad food or bad water that we consume. So A and E are a separate topic altogether. But just to give you a gist of how is the burden here in India, how is the hepatitis A scenario in India. Coming to our main topic for today for hepatitis B and C. So I'll be talking of hepatitis B burden first for India. About 257 million people are affected with chronic hepatitis B globally, resulting in over around 9 lakhs deaths annually. And more than 90% of these deaths and disabilities are as a result of viral hepatitis attributed to chronic hepatitis B and C infections. So this is the prevalence of Hbsag, that is hepatitis B surface antigen in Southeast Asian countries. And as you can see, here is India with 1.7% in comparison to other Southeast Asian countries. So World Health Organization has set a mandate to eliminate viral hepatitis as a public health threat by 2030. And it requires that new chronic hepatitis B infections be reduced by 90% and the mortality attributable to these infections be reduced to 65%. So these are the 65, like if in 2020 there were 10% reduction of this, so we aim to have 65% reduction by 2030 for these deaths and 90% reduction in the new cases here by 2030. So based on the prevalence of hepatitis B surface antigen, the world is classified into high, intermediate or low Hbv endemicity. And India falls into intermediate endemicity zone with an average of 3 to 4%. But Hbsag positivity in the general population, it ranges from 1.1 to 12.2%. 10 to 15% of the entire pool of Hbv carriers in the world is in India, with over 40 million Hbv carriers. And about 15 to 25% of these carriers are likely to suffer from cirrhosis and liver cancer and may die prematurely. So coming to the estimated point prevalence, as you know, point prevalence of HBV in India. So it comes to, as I said.
Here we are to
Okay. So earlier, like there are varied literature numbers in here for the prevalence mark. So earlier, like in my previous slide, it was 3 to 4%. So the point prevalence of India, as per the reference shared below, it is 2.4% with the confidence interval between 2.2 to 2.7. And it is particularly high in the tribal areas, ranging up till touching up till 16%. So these are the various references if we talk about the prevalence of chronic hepatitis B infection. So there is this reference from Schweitzer et al. So this gives the prevalence, point prevalence of 1.46%. As per the WHO, these references are here. So it is 1.95%, and CDA Polaris say that it is somewhere in in the range of 2.5%. So as per these numbers, if we see the previous slides, so as per these numbers, it is less than, like it falls somewhere between low to intermediate endemicity for HPV. So these are the estimates of the worldwide prevalence based on a systematic review that was done between for the data published between 1965 and 2013. And these estimates say that it is 1.44% for 1990 to 2013, and the prevalence from 2.62 from 1957 to 1989. And these are the CI confidence interval and number of studies in which the system for which the systematic review was done, and number of subjects. Then talking about the heterogeneity from the various literature reviews, then there is population heterogeneity for hepatitis B in India region wise. Like in Ladakh, there have been studies which gives the prevalence as 12.7%. For Northeast India, for Arunachal Pradesh, there's been a study giving it as 21.2%, which these numbers are like relatively higher for what we are seeing at the national level. And so as for the tribes of the Andaman and Nicobar Islands, ranging from 23.3% to even 65% in the Jarawa population. So coming to the hepatitis C virus scenario in India, so prevalence rate of HCV viremia in India in 2015 was 0.5%, so affecting from around 5 to 11 million people. And the anti-HCV antibody prevalence was somewhere between 0.09 till 15%. So chronic HCV infection accounts for around 12 to 32% of HCC and 12 to 20% of cirrhosis cases. So this is where India lies in the prevalence numbers in Southeast Asian region countries at 0.56%. So prevalence rate of HCV in India in a meta-analysis from 327 studies as estimated by the seropositive rates of anti-HCV antibody. We have different numbers for different areas. Like in community studies, the prevalence rate was 0.85%. In asymptomatic blood donors, it is nearly half to that point, the 0.44%. And in pregnant women, it is about 0.88%. So there is particularly high prevalence of HCV when we talk about high-risk individuals, including patients with HIV infections, patients receiving hemodialysis, IV drug users, patients requiring multiple blood transfusion, and patients with high-risk sexual behavior and attendees of STD clinics. So here the prevalence of HCV ranged from somewhere between 3.5% to 44.7%. They have calculated, certain studies have calculated the pool prevalence rate of HCV Hbv co-infection and HCV HIV co-infection. So again, from the literature review, a meta-analysis of 30 studies showed that Hbv HCV co-infection pool prevalence was 1.89% in India, and prevalence rate of antibodies to HCV ranged between 7.2 to 76.6% in patients with HIV. So then hepatitis B and C, they account for a number of complications, and two major complications are cirrhosis and hepatocellular carcinoma. So I've just drawn the numbers again there, that HBV leads 40 to 50% of HBV infected patients, they end up in having a hepatocellular carcinoma, and 20 to 30% of HBV infections, they end up in cirrhosis. So HCV, the numbers are relatively less, 12 to 32% for HCC from like if you talk about hepatitis C virus, and 12 to 20% for cirrhosis. So all these numbers, I know this is a lot to take in, but all these numbers, there is a limitation to the current literature as far as we can see, that there is a difference in the quality of the reporting variable. And then it is a combination of robust and non-representative studies across different age groups and different time points, so accounting to different point prevalences. And there is a paucity of age-specific and sex-specific data, and the data for infants and young children. And these studies are mostly done at the sub-national level, and where, like in certain areas like the Jarva population, the high indemnicity areas. So since today this like modes of transmission is not being taken up quite extensively in today's sessions, so steps needed for policy are mainly related to the modes of transmission and at the health system level. So birth dose of hepatitis B vaccine is a mandate, safe blood products and medical procedures, screening and monitoring strategies, occupational safety, as ma'am said, that dental surgeons are particularly more at risk to this, the occupational hazard. And then high indemnicity areas need to be focused on. Surveillance system needs to be established for chronic liver disease, testing and treatment, and the vaccination for health workers. So these are again some numbers from Global Health Sector Strategy on Viral Hepatitis. So these are the this is the baseline that we had in 2015 for these interventions, and we are targeting to reach like 90% for vaccination, 90% for prevention of mother-to-child care transmission, 100% in blood safety, and 0% in unsafe injection, and so on. So we talk about the pillars for HBV elimination. These are immunization, prevention of mother-to-child transmission, safety at the level of blood banks, dialysis, safe injections, and biomedical waste disposal, and harm reduction for persons who inject drugs, de-addiction and opioid substitution programs, and expanding access to care so that we can ensure that we have testing as well as the treatment to those who are testing positive. So again, these are the challenges in managing the hepatitis B in India, which are in line to what we have already talked about. So the last section is the public health approach. So it is now high time that we correct the course of evidence-based practice by improving immunization coverage and expanding access to care in chronic hepatitis B. And the appropriate population screening and treatment strategies need to be adopted in a decentralized fashion under the National Program for Viral Hepatitis Elimination. Creation of a national viral hepatitis and transplant registry will improve the poor epidemiological data that impair formulation of appropriate healthcare policies. And India's emergence as a hub for affordable transplantation offers hope for management of advanced disease and curative therapy for hepatocellular carcinoma. Thank you so much.
Thank you so much, ma'am, for such a wonderful presentation and enlightening us with the knowledge. So now I would like to introduce our next speaker, Dr. Tushar Prabhakar, who will be discussing about screening, vaccination, strategy, and health education for HBV and HCV virus at community level. Dr. Tushar Prabhakar is a senior resident in Department of Clinical Research and Epidemiology, ILBS. He graduated from University College of Medical Sciences, Delhi, and recently completed his post-graduation from Lady Hardinge Medical College, Delhi. During his residency, he has worked in the fields of core patient management, essential drugs and medicines, health systems, and strengthening infectious and non-communicable disease epidemiology, reproductive, women and child health, family planning services, malnutrition, and immunization activities. As a digital health specialist, he was the departmental representative to assist and train members in LHMC for COVID-related data handling and operations at Delhi State Government, Data Management and Portal Comcare Delhi Fights Coronal Portal. A creative enthusiast, he has won the first prize in numerous national conferences of IAPSM and IPHA for Best Educational Video and Best Educational Meme competitions. Over to you, sir.
Good morning. The topic for me dedicated today is viral hepatitis B and C, screening, vaccination, and health education. So we'll be covering the following topics, wherein we'll be talking about the screening first, and we'll talk whom to screen and the various screening tests available for hepatitis B and C. And then we'll move on to vaccination, wherein we will talk about the types of hepatitis B vaccines available, the schedule for vaccination, and what to do if somebody misses a dose of hepatitis B vaccine, and the overall coverage of vaccination across India, and the strategies to improve hepatitis, especially the bird dose coverage. And finally, we will touch upon the health education, which is an important parameter to spread awareness regarding elimination of hepatitis. So why focus on screening? So this is a WHO graph which shows the cascade of viral hepatitis prevention, diagnosis, care, and treatment. And as we can see, of the total number of people who have hepatitis, only a few are getting actually tested and aware of their status. So in order to increase the diagnosis and the awareness, elimination of the hepatitis by 2030, it is important that we attend to this bottleneck, which is low level of diagnosis and screening. So screening is the key to improve diagnosis of hepatitis. So the key interventions, as already discussed, to eliminate hepatitis are hepatitis vaccination during childhood and birth dose, safe blood practices, safe injection practices, harm reduction, and hepatitis B and C diagnosis and treatment. So our area of focus today will be primarily hepatitis B and C diagnosis. So according to WHO Global Health Sector Strategies, Service Delivery Target for Diagnosis, to eliminate hepatitis B and C by 2030, we need to diagnose at least 30% of the total people with hepatitis by 2020, and the target has to increase to up to 90% by 2030. But as we can see from the 2019 WHO Southeast Asia region, of which India is a part, the service delivery target for diagnosis achieved in India is only for India and the Southeast Asia region. For hepatitis B is around 10%, and for hepatitis C it's only 6.9%. So we are far below the recommended 30% by 2020 target set by the WHO. So whom should we screen for hepatitis B and C? So according to the National Program for Hepatitis, screening services should be extended to all, and at all peripheral institutions like healthcare, health wellness centers, and primary health centers. So whoever is visiting these testing centers should be given the right to get screened for hepatitis B and C and know their status, especially those who are at high risk. If there is a paucity of testing kits, preference should be given to those who are at high risk. So who are these people who are at high risk? So pregnant women, injectable drug users, healthcare workers and frontline workers, people who are on hemodialysis, and people with HIV/AIDS. So these are all people who are high risk, and they should be given preference for screening for hepatitis B and C. So how do we go about the screening? So screening tests, rapid diagnostic test kits are available, and the good thing about them is that they are single-use disposable assays, and they're cheap. They cost less than 50 rupees per unit, and they are simple to use formats and can be used at all peripheral health centers. They don't require much additional reagents, and they're they can be easily read visually, and they give a simple qualitative result within 30 minutes. So for hepatitis B and C, we have these kits. wherein for hepatitis B, we are assessing, detecting the hepatitis HbS antigen. And for hepatitis C, we are looking for the anti-Hcv antibodies. So now, as we can see, the sensitivity and specificity for these kits are quite high. And so the results obtained by these cheap and low cost, cost-effective kits are very reliable. So anybody who, whenever we send a patient for screening, and if suppose we get a positive result on these kits, we can most probably assume that they have the hepatitis, and then they can be sent to the higher centers for confirmatory diagnosis and treatment. So now, as we know, hepatitis B does not have a proper treatment as such. So the best way to eliminate hepatitis B especially is to prevent its occurrence. So the primary method for prevention of hepatitis B, or for that matter any other vaccine preventable disease, is vaccination. So hepatitis B vaccine, it's basically a recombinant subunit vaccine which contains a viral protein whose name is Hbs antigen, and it's a hepatitis B surface antigen. So nowadays only the recombinant protein is used. Originally it was produced from the plasma of people with chronic Hbv infection, but that's no longer used. The common types of hepatitis B vaccine which are available are either monovalent or in combination. A monovalent vaccine by the name of Antigen B. So we have it in two, as you can see, two color-coded vials, one for the adult and one for the child. The dosage for both the categories would be different. We'll talk about it. So other than the monovalent vaccine, we give hepatitis B vaccine in combination. So under the Universal Health Program, Universal Immunization Program for Government of India, children less than the age of from 6 to 10 and 14 weeks are given hepatitis B in the form of a combination vaccine, which is a pentavalent vaccine. So other than hepatitis B, we also have additionally 4 more vaccine preventable diseases components in the vaccine, which are diphtheria, tetanus, pertussis, and hemophilic influenza B virus. But if you go to the private setups, we have an additional hexavalent vaccine which people can opt for, which has an additional 6th component for injectable poliovirus. So these comes under the name of Infarex and XSN. So now hepatitis B can be given both to, ideally it should be given to the newborn and the infant, and also in adults in case of healthcare workers or people who are at high risk. So the dosing schedule for newborns is a 0 birth dose, which is the monovalent vaccine, which should be ideally given at birth or within 24 hours after birth. And then a primary 3-dose schedule, which includes 3 doses of the pentavalent vaccine or the hexavalent vaccine at 6, 10, and 14 weeks of age. So this is given as in the dosing of 0.5 ml intramuscularly. For the adults, we can see that the quantity is 1 ml intramuscularly, and it's given at a schedule of 0, 1, and 6 months. And it's the monovalent vaccine that we use for adults. We'll briefly talk about the vaccine protection rate. So if a child gets the 0 dose at birth and 2 doses of primary child immunization, so we can prevent mother to child transmission by up to 90%. So in case a mother has hepatitis B and she's expecting, and the child, as soon as it's born, we give the birth dose and 2 doses. So the chances of having hepatitis in the infant are reduced by 90%. And if the child, for any child, if we complete the 3-dose vaccination schedule of hepatitis as suggested by the WHO and the Indian Immunization Program, so the first dose, which is given at 6 weeks, gives a protection rate of 16 to 40%. Whereas if we give 2 doses at the 6th and 10th week, the child is protected from hepatitis by up to 80 to 95%. And if we complete the whole 3 doses, it gives an almost protection of 98 to 100%. So what if the child or an adult misses a dose at the prescribed time? So under the Universal Immunization Program, the birth dose should be given at birth, but it can be given up to 24 hours after birth. But as we prolong the time, the chances of mother-to-child transmission increase. And the primary childhood doses, which are recommended at 6, 10, and 14 weeks, can be given up to 1 year of age. So suppose a mother comes with a child at 6 weeks and then 10 weeks and then forgets or misses the 14th-week dose. So that dose can be taken up to the age of 1 year of the child, provided the duration between any two doses should be at least 4 weeks. In case of adult immunization, if only first dose is taken and the second dose is missed, so as soon as possible, when the patient comes next, you should administer the second dose. In case first and second dose are taken at 0 and 1 month and the third dose is interrupted, again, it should be administered as soon as possible, provided the interval between the second and third dose is at least 8 weeks. In certain cases, when we are not the vaccination history is not reliable or not available, extra doses of single antigen hepatitis B vaccine can be given as it's not harmful. So in case of pregnancy, neither pregnancy nor lactation should be considered a contraindication to vaccination. Moreover, pregnant women who are at risk of HBV should take the adult dose of vaccine if they have not taken, in order to prevent mother-to-child transmission. And also the child should further take human immunoglobulin and the bird dose and all the 3 primary doses. So who are these pregnant women who are at risk of HBV? Those who have had more than one sex partner during the previous 6 months, or are being evaluated or treated for a STD, or have had a recent or current injection or are chronic drug users, IV drug users, or they have had a positive hepatitis B positive sex partner. So how do we know if the vaccine is working? So we check for the anti-Hbs titer. A serum level of more than or equal to 10 milli international units per ml is protective. So we need to get this testing measured just once, and if the patient has a level equal to or more than 10, we can consider that the person is protected. So this titer is used as a cutoff to define the vaccine response. So over 90% of the people remain protected for at least 30 years once they get the full 3 doses of primary immunization. So we'll talk about the adverse events. So mostly local reactions like pain, swelling, and redness, and sometimes temperature more than 37.7 or mild headache. These can be seen commonly, as is with any other vaccine, in up to 3 people per 100 people. Sometimes, rarely, we see that the vaccine is causing a severe allergic reaction, which is known as anaphylaxis. This, if a person has got a dose of hepatitis B and he develops anaphylaxis, then it becomes contraindicated and should not, further doses should not be given in that particular case. So about the hepatitis B vaccine coverage. So WHO Global Health Strategy for elimination of hepatitis. So it has set a key service target that in order to achieve elimination by 2030, primary 3 dose of 6, 10, and 14-week hepatitis B vaccination should be 90% of the children being born should be covered by 2020, and it should be 90% by 2030. Whereas for the hepatitis bird dose, by 2020, 50% of the children being born should have the bird dose, and by 2030, 90% of the children should have the bird dose. According to the NFHS 2019 data for India, India is doing pretty good for the primary 3-dose coverage, with 84% children being covered, receiving all the 3 primary doses. But as we can see, the dosing for the bird dose for India is only 56% as of 2019. In India and other developing nations, the percentage of bird dose is low because of things like high prevalence of home deliveries. So the mothers don't go to the hospital to get their deliveries done, so they miss on getting the hepatitis B vaccine for the child within 24 hours. And other issues like logistic issues like absence of cold chain in peripheries and small villages. So availability of vaccine is also an issue. So now this is a graph which is showing the importance of the bird dose. So as we can see, the purple line, it is showing the percentage of children or people who develop chronic hepatitis B depending on what age do they get infected. So as you can see, if a child gets hepatitis B at birth, the chances of having chronic hepatitis B is over 90%. And as the child becomes older, and children 5 years or above, if they get hepatitis after the age of 5, the chance of having chronic hepatitis B is very low, less than 10%. So this means that infections during infancy and early childhood are particularly likely to lead to chronic infection, which in turn with high risk of cirrhosis and death. So in order to prevent or in order to increase the coverage of bird dose of hepatitis B, recent advances like controlled temperature chain are being tested. So which is an innovative approach which allows vaccine to be kept outside the cold chain. It can be kept at room temperature for up to 3 days. And this is being tested for some heat stable vaccines, one of which is hepatitis B. So in case after a point of time, we'll be able to know if this is really efficacious, and then probably we can apply this controlled chain, temperature chain strategy in our villages or peripheries. So we'll briefly touch upon health education measures that we can do to prevent. Prevention is always better than the cure. So some of the strategies applied, especially by LBS, there can be exhibition posters or some competitions involving school children to spread awareness at a ground level, or hiring of a stakeholder who can take the voice to the masses. Use of social media to express and propagate the message of prevention of hepatitis, and then have campaigns and involve stakeholders so that measures can be taken up at a institutional level. So these are some of the posters released by ILBS, which one of which is on that fact that hepatitis C is curable. One which shows that pregnant ladies should get tested and vaccinated for hepatitis B. One which promotes vaccination for 0 and primary 3 doses of children. Some other general posters. Then a cartoon competition was held, which involved students from over 40 countries, and it helped in generating posters which were posted on the websites and propagated across many media. And this is a Happy School campaign wherein principals and selected teachers from all government schools of Delhi were invited to attend interactive session on how to prevent hepatitis so that they could further disseminate the data or the information among their peers and the students. I Pledge campaign is also done, wherein we'll be doing it again today by the Empathy campaign to make people self-aware and realize the importance of keeping their liver safe and prevent hepatitis. So Empathy campaign from ILBS, we have hired Mary Kom, who is everybody knows the world boxing champion, to propagate the message of hepatitis prevention and awareness. And we have had conclaves with stakeholders in the past wherein parliamentarians and ministers have come on board and to set up terms to prevent and so that we can achieve the target of elimination by 2030. Many faculty videos are available on social media like Twitter and Facebook, and we have the link to the website wherein people can go and get educated. To summarize, diagnosis is a key bottleneck for the prevention and elimination to achieve elimination of hepatitis. So the solution is to screen. Rapid diagnostic tests are easy to use, quick results, cheap, high specificity and sensitivity methods to detect presence of hepatitis, and so that they can be moved ahead for treatment. And primary 3 doses of hepatitis B vaccine gives a protection rate of over 90 to 100%, whereas bird dose and 2 primary doses prevents mother to child transmission by over 90%. Anti-HBs titer of over or equal or more than 10 milli international units per ml means adequate protection against hepatitis B. Thank you.
Thank you so much, sir, for such an informative presentation. The next speaker for today is Dr. Shakila Mahesh, who will discuss about post-exposure prophylaxis. Dr. Shakila Mahesh, she has done her postgraduate from Dr. ALM Postgraduate Institute of Basic Medical Sciences, University of Madras. She has 13 years of teaching experience in dental college. She has completed her PhD from SGT Medical College and is currently teaching undergraduate and postgraduate students. She is a keen researcher, a guide to postgraduate and PhD student. Over to you, ma'am.
Good afternoon, one and all who are present for the webinar. It was an interesting speech by both the speakers, and probably some of the points I might have to repeat because otherwise I will not meet a flow to the presentation today on post-exposure prophylaxis of both HBV and HCV. Mostly the target will be among healthcare workers, so it's not going to be on general population, but the topic is relevant to the healthcare workers. So as discussed earlier, it's a blood-borne viral disease, and it can produce chronic infections, and it can also cause hepatocellular carcinoma, and it is transmissible in a healthcare setting. So that is why this topic becomes very interesting and important for dentists. Right, the route of transmission is mostly percutaneous, which means that through a puncture through skin or through a sexual route by injection drug use, or it could be by the mucosal surface. The direct contact with mucous membrane, exposure to infections of blood or body fluids. This is where it becomes risky for the healthcare workers. It can also be transmitted in the absence of visible blood, which could be highly infectious and remains viable in the environment surface for at least 7 days. So the risk is higher when you compare it with other blood-borne infections like HIV. Persons with chronic infection, those with persistent hepatitis B surface antigen, this is the most important antigen which is present on the surface of the virus. The structure of the virus is very important because we need to know what is the seroprotection which you achieve after the vaccination. And two other antigens are important in the surface of one is the hepatitis B surface antigen, the other is hepatitis core antigen, and the other is E antigen. So you see then the serum for at least for 6 months following acute infection, then you state that the person is chronic infection, and he may serve as a reservoir for HBV transmission. So further, what you see is the risk interpersonal contacts like sharing of toothbrush or razor, or contact with exudates from dermatological lesions, or contact with Hbsag contaminated surfaces. Settings could be anywhere like school, childcare, or any crowded area. And transfusion of blood and blood product is very rare nowadays because the donor screening and viral inactivation procedures are intact nowadays, so the chances are very rare. Contaminated medical or dental instruments, unsafe injections, needle stick injury, organ transplantation, and dialysis are the most important reasons for the transmission of the disease among healthcare personnel. So this has been already discussed: people with risk of occupational exposure to HBV, people with HCV infection, those who have chronic liver disease, and travelers to countries where HBV is endemic, people with HIV, and people with diabetes are at high risk of getting the disease. Further, the most important thing is, other than Hbsag, when we see the HBV risk varies depending on the E antigen status of the source person. Source person here, I mean that it may be a patient who might be infected and who would transmit the disease to a healthcare personnel. So if the E antigen positive risk is up to 30%, right? And if it is an E antigen negative person, then the risk is up to 1 to 6%. So we never know, for example, if a patient is coming in with a positive status with HBe antigen, so the risk would be up to 30%. HCV risk is about 1.8%, which could range from 0 to 7, and HIV risk is about 0.3%. So these are important things when you want to see that through a percutaneous exposure, what could be the risk in a healthcare worker. So if you see the concentration of these samples, if you see what is the risk factor here, like high, moderate, and low or not detectable, blood, serum, and wound exudates are put into the category of high risk, and moderate you have semen, pericardial, vaginal, saliva, where we dentists come in contact with saliva very frequently, pleural, amniotic, CSF, and synovial. Low and not detectable are urine, feces, tear, breast milk, sweat, nasopharyngeal washings, vomitus, sputum. That's why breast milk is not a contraindicated indicated in mothers who are positive for HBV. So next, if you see in the dental professional, when you have a mucocutaneous exposure or a percutaneous exposure, the data shows that about 2 million dental healthcare professionals worldwide are exposed to blood as well as saliva of the patients. Up to 3 to 10 times dentists are more prone to HBV than the general population. And zero prevalence of HBV is up to 9%, and in Hcv is 1.4% in dental profession, according to the latest data shown through some of the publication in a very good journal. So it is reported that 85% exposure among dentists due to small field of work with frequent patient movement and proximity to sharp instruments. That is the reason why the healthcare worker and mostly dentists are prone to the disease. Fingers are the most commonly affected, followed by the thumb and then the hands. The common instruments which the dentists come in contact are needles, anesthetic local or drilling instruments, endodontic files, and lab knife. These are the common instruments through which you could get a finger prick or any kind of accidental injury to your hand. Okay, this data shows actually that, for example, if you have a needle prick, serological status of the source. Source here means the patient. Where hepatitis B surface antigen positive, we can see risk in developing clinical hepatitis could be up to 22 to 31%, and risk of developing serological evidence of HBV up to 37 to 62. Whereas if you are HBsAg positive and HBe antigen negative, the risk is slightly less, 1 to 6%, and risk of developing serological evidence would be 23 to 37%. So if you see, these are the two important antigens of the HIV virus. One is the hepatitis B surface antigen and the other is hepatitis B E antigen. So when a source person is positive for both these two antigens, then the risk of developing clinical hepatitis will be higher. So if you see this data, healthcare workers exposed to bloodborne pathogen is up to 5.9% for HBV, which corresponds to up to 66,000 Hbv infections in healthcare workers worldwide. So you can see the risk here for the healthcare workers. And in developing countries, you can see 40 to 65% of Hbv infection in healthcare workers were attributed to percutaneous occupational exposure. Okay, so what we see is prevention. How do you prevent this type of mishap or infections which could happen in a healthcare setting? First is to promote hepatitis B vaccination, treat all patients as potentially infectious, use barriers to prevent blood-body fluid contact, and prevent percutaneous injuries. Further implementation of standard precautions, availability of proper sterilization equipment. So all dental clinics should have a proper sterilization equipment where whatever is being used has to be sterilized. Implementation of universal work precautions, appropriate biomedical waste management, and proper arrangement of management of accidents is example like spill kits, etc. So preventing, how do we prevent these type of injuries? Eliminating unnecessary needle use, using devices with safety features, developing safe work practice for handling needles and other sharp devices, safe disposing of sharps and blood contaminated material. Okay, this is an interesting slide here, safer medical devices, or we can probably use these type of self-resheeting needles here. If you can see, these are self-resheeting needles, which automatically closes once you use it. And this is a syringe with retractable needle. So the needle retracts back so that you don't get injured while you are injecting. Then blunt tip blood drawing needle. So if you see, the tip is actually blunt so that it doesn't pierce further. So it retracts back. So as you draw blood, then a blunt tip comes forward. So this way you're safe. And here you see winged steel needles. So you have winged steel needles, resheathing disposable scalpel. So this goes off, the sharp edge of the scalpel goes off while if you're using this type of a device. Add-on safety features, right? And retracting finger prick lancets. For example, if you're using a lancet, then it retracts back. So nothing is exposed here. The sharp point of the syringe or the needle is not exposed so that you don't get a prick that easily. So this type of safer medical devices can be used in clinics or in hospital or any kind of setup so that you don't get a risk of getting a finger prick. Right. While handling sharps, the most important thing is you should have some container, a biohazard container, very close to your dental chair when you want to discard any kind of needleless syringe, right? And make sure that if you have a full point here, it should not go beyond that. And if you see this picture here, you can see that all the needles are exposed out, and this could also be a risk of those who are going to handle this kind of a plastic device or instrument while discarding them. Right. There's something called as a biohazard spill kits. This also can be acquired in your personal clinics or in hospitals. This biohazard thing has, biohazard spill kit has a disinfectant. It has some glove material. It has some plastic bags with it. It has some mops. So any kind of blood spillage, you can immediately pour disinfectant over it, and then you have to wear a rubber glove and mop it with the help of these type of material which is given and discarded into the plastic bag, and this has to then finally be discarded into a biomedical waste color-coded bag. So this color-coded bags, probably you know, there are black, red, yellow, blue, and white. Mostly if you see needles and cut glasses have to be put into the white, and syringes, gloves, and plastic waste can go into a blue, and infected dressings, etc., can go into a red. So depending upon that, what kind of waste is being generated, that you can further discard into the color-coded bag. I will not go into the detail about the biomedical waste management because I would emphasize more on post-exposure prophylaxis. So if you see this, hepatitis B vaccine or hepatitis B immunoglobulins, these are the two primary agents which are used for as a vaccination or prophylaxis. Hepatitis B vaccination is the mainstay of hepatitis B prevention efforts, and Hbig, that is hepatitis B immunoglobulin, is generally used as an adjunct to hepatitis B vaccine and certain other post-exposure prophylaxis situation. Right, this happens even during perinatal care. If you see that if the mother is positive and the infant born could have a risk of getting a disease, then you can, along with hepatitis B, you have a Hbig that could be added as an adjunct. So the same thing can be practiced even for post-exposure prophylaxis. So vaccine already has been discussed by Dr. Tushar, so I wouldn't go into the detail. So what we use is a yeast-derived Hbsag purified vaccine, which has replaced the plasma-derived vaccine. And one more thing which he emphasizes, the recommended dose and formulated to contain 10 to 40 microgram of Hbsag protein per ml of the dose which you use. And there is a 3-dose regime, you call it as a series of 0, 1, 2 to 1 to 2 months and 6 months, where you see that the hepatitis B antibody should be obtained within 1 to 2 months. So if a person who's been vaccinated and he achieves the production of hepatitis B antibodies, then you call that person as a responder. So this is after completion of the 3rd dose. For those who do not respond, we call them as the non-responders to hepatitis B vaccination. In that case, we have to administer Hbig alone in the primary means of protection after an Hbv exposure. So most of us actually have got vaccinated, but none of us see what is the level of antibody which has been produced after your vaccination. This is very important, that what is the level of antibody in a person who has got 3 doses or a complete series of vaccination. So Hbig provides only passively acquired anti-HBs, which means that antibodies to hepatitis B surface antigen, and it gives a temporary protection of 3 to 6 months. So passively acquired anti-HBs can be detected for 4 to 6 months after the administration of HbIg. Right, what kind of seroprotection do you get after the vaccination? Person who recover from natural Hbv infection are typically positive for both anti-HBs and anti-HBc. This is the core antigen and this is the surface antigen. So if you have a natural infection with HBV, then the type of antibodies normally produced are against the hepatitis B surface antigen and against the hepatitis B core antigen. Whereas a person who responds to hepatitis B vaccine are positive only for anti-HBs, which means that antibodies are only produced against the surface antigen. So immunocompetent children or adults who have vaccine-induced anti-HBs level, this also he had mentioned that more than or equal to 10 milli international units per ml 1 to 2 months after having received a complete hepatitis B vaccine series, which means that the 3 doses is finished. Then the person is called as seroprotected and deemed vaccine responder. So we actually need to, those who have been, we had a hepatitis B vaccination schedule in our college, and we have to actually check what is the status of the antibodies which are produced to call ourselves as responders. So it has to go beyond more than or equal to 10 milli international units per ml. Right, vaccine-induced seroprotection, some data which you have to remember is vaccination at the age less than 1 year, because at our times we did not have this as a mandatory vaccine, but now children, most of them are at after birth itself you have a vaccination. So if you get vaccinated at an age less than 1 year, then 16% will have antibody level of more than or equal to 10 milli international units per ml, even after 18 years following vaccination. If you have got vaccinated beyond 1 year of your life, then 74% will have antibody level of more than or equal to 10 milli international units per ml. If you get a challenge dose of hepatitis B vaccine 30 years after hepatitis B vaccination as children or adult, then you will have an 88% protection, which means that antibody response of more than or equal to 10 milli international units per ml, indicating persistent immunity to HBV infection. So a 3-dose hepatitis B vaccine series will produce 95 protection. Adults age less than 40 years. I don't know that the data, if you go beyond 40 years or if you get vaccination after 40 years, what is the data? So adult age 40 years, this also has been discussed that in the first dose, you get 30% to 55% anti-HBs level. And in the second dose, you get up to 75%. And only in the third dose, you get a efficacy of up to 95% protection. So all the 3 series have to be finished to attain an antibody level of more than or equal to 10 milli international units per ml. Right, some of the markers which you have to know when you are looking, for example, if you want to check the status of the source person or check the status of the healthcare person. So this is the first hepatitis B surface antigen. If a person is hepatitis B surface antigen positive, which means that the patient is having an acute current infection, either acute or chronic, and transient Hbsag positive can occur up to 18 days following vaccination too. So this is transient, which means that after some time it will disappear. And if in case, if he's a hemodialysis patient, then it could be 52 days. Then if Hbsag persists for more than 6 months, then you call the patient as chronic, right? And if anti-HBs within 3 to 4 months, which means that the Hbsag disappears and you have antibodies which are formed against hepatitis B surface antigen, right? Indicative of immunity. So if you are developing antibodies to the surface antigen, then it means that you have immunity to HBV infection. If you have anti-HBc, which means the antibodies to hepatitis B core antigen, which could be initially both IgM immunoglobulin or IgG, appears 1 to 2 weeks after appearance of hepatitis B surface antigen. So the first antigen which appears will be hepatitis B surface antigen, and later on you'll have antibodies which could be formed against the hepatitis B surface antigen and antibodies to hepatitis B core antigen. So the 2 types of immunoglobulins here is IgM, which is an early immunoglobulin, and IgG is a late immunoglobulin. So acute infection, if IgM appears, then it disappears within 6 months, and 10 to 20% chronic patients with reactivation or flare-ups also will have IgM immunoglobulin. Then IgG indicates exposure, mostly lifelong immunity. It gives a lifelong immunity and also occurs in occult HBV, which means that if the liver has HBV DNA in it, right? So HBV DNA, this is also an indicator of infection, which measures the viral load, and it also measures the reflection of viral multiplication. So the viral replicates at this particular stage where you can come across HBV in the blood or serum of the patient. This is prior to HBsAg. Then presence of HBV DNA, and if HBsAg is undetectable, then you call it as an occult infection. And if you see hepatitis B E antigen, acute or chronic HBV infection. And if you see antibody to HBe antigen, then loss of replicating virus, reversion to HBeAg positivity can occur in such patients. So these markers are actually important. It could be too much to understand, but these are the important markers which are seen in the early stages of the disease, and antibodies to which they are produced at each and every stage of your infection. So coming to the post-exposure prophylaxis, what do you need to do when you have a finger prick or you come in contact with the blood or body fluids? Probably it could be infectious wound and skin sites that have come in contact with this. First thing what you need to do is wash with soap and water. Mucous membrane should be flushed with water. This is the first step which you have to do to prevent the infection. Using antiseptic 2% or 4% chlorhexidine is actually not recommended for wound care. Squeezing also is not recommended. Squeezing of the wound is also not recommended. It has not shown to reduce the risk of HBV transmission. However, the use of antiseptic is not contraindicated, right? So not much data here that whether the antiseptics will be useful or not, but then it is not contraindicated too. Application of caustic agents like bleach or injection of antiseptic disinfectant into the wound is not recommended. So you're not going to do any of this. The best is wash with soap and water, and if mucous membrane, then it is flushed with water. Right. The source is evaluated for risk factors like history of risk. For example, if you get a finger prick, then what all kind of a history, before you treat a patient also, you need to take a history of all this. Knowing to know about the sexual behavior, men having sex with men or multiple sexual partners, or sexual partner in whether who's an intravenous drug abuser, or infected with Hcv or Hbv, or who a patient who is from highly endemic area, or history of blood transfusion before 1990, where the screening of the blood was not much done earlier. So serological testing of the source patient for HBV, HCV, and HIV is the most reliable method to assess risk of exposure and should be strongly encouraged. If the source refuses, then Mandatory Blood Testing Act 2006 should be followed. Testing of needle and other sharp instrument is not recommended. So you don't have to do this at all. So what you need to know is the patient history, right? Know about the patient history and whether he had an infection or from where he is, any particular endemic area, right? Or whether he had some blood transfusion earlier. The source exposed HCV, which means that healthcare personnel should also be investigated for baseline serological investigation for HBV, HCV, and HIV, irrespective of whether or not prophylaxis is indicated. So if you feel that probably the source had all these type, maybe he had some blood transfusion or probably a potential hepatitis B carrier, right, which is very hard to know actually. But then what kind of precaution you're supposed to take? So liver function tests are also important for baseline testing, because without baseline data, any further claim of compensation for occupationally acquired bloodborne illness could be jeopardized. Repeat HCV and HBV testing at 3 months, 6 months is advised if baseline sample is negative. So if you have done a baseline sample and if it is negative, repeat the test after 3 and then 6 months. Then exposure should be quickly evaluated and should be notified to the concerned authority of the institute. So any kind of exposure to blood and body fluids by prick or accidental injury, then you have to notify to the nodal officer. Post-exposure counseling of HCP is an essential part of the management, because you become highly sensitive that probably you have got a finger prick or you have been exposed to the virus, and maybe you may fear that you may get infected or you may turn to be positive. So counseling also is required. Right. This table is very interesting, and everyone should know this as a healthcare personnel. So this contains an HCV status, HCP status, healthcare personnel status, post-exposure testing, post-exposure prophylaxis, and post-vaccination serological testing. For example, documented responder after complete series, which means that documented that in that case, no action is needed. You don't have to do anything. You have been vaccinated and you know what is your status of your antibody. So you don't have to do any kind. You don't have to have any kind of testing, or you don't have to undergo any kind of vaccination. For example, documented non-responder after 2 complete series. In that case, if you know the source patient is Hbsag positive or maybe unknown to HCP testing, no data here available, but post-exposure prophylaxis, you have to get Hbig into 2 doses separated by 1 month apart. No vaccination required. Post-vaccination serological testing is not applicable, right? Third category is response unknown after complete series. So you don't know what is your response. You don't know what is your antibody level. You have been vaccinated. You have all the 3 vaccinations which you have got, but you don't know your the antibody level. For example, you know that the source patient is Hbsag positive or unknown to. Then you need to do an HCP testing, right, of anti-Hbs of the source person. If you find that it is less than 10 milli international units, then what you need to do is Hbig into 1 dose and initiate revaccination. And you also have to do a post-vaccination serological testing. For example, if the source person is Hbsag negative, right, and the antibody level is less than 10 milli international units per ml, then you don't have to do anything, none Hbig, but initiate revaccination. Next is any result. You have got positive or negative, less than 10 milli international units per ml. You need to initiate revaccination, and you need to post-vaccination serological testing also has to be done. So probably we are in this category. We don't know what is our antibody level, right? We have been vaccinated. We have done a complete series. We don't know the response, right? So in that case, you have to initiate revaccination if you feel that the source patient is Hbsag positive. You have done a testing to this person and you know that he is Hbsag positive, right? Then the 4th category is unvaccinated, incompletely vaccinated, or vaccine refusal. Those who have refused the vaccine, or those who have not completed the vaccination, or those who are unvaccinated. In that case, if you find the source patient is Hbsag positive, right, you need to go ahead with Hbig into 1 dose and complete vaccination. And you also have to do a post-vaccination serological testing. Similarly, even if the source patient is negative, you don't have to go ahead with the Hbig, but you have to give a complete vaccination, and post-vaccination serological testing has to be done. So this is the important thing which you have to know for post-exposure prophylaxis, depending on whether you are a responder, non-responder, or you don't know whether you are not been vaccinated. In that case, what kind of precaution you're supposed to take, right? So both Hbig and the first dose of hepatitis B vaccine post-exposure should ideally be actually administered within 24 hours of exposure to blood and body fluids. Hbig should not be given after 14 days of exposure. So there is no use of giving Hbig if you have been exposed for more than 14 days. So anything which you have to do it within 24 hours of exposure. So the Hbv vaccine series has 3 doses. This you know, and hepatitis B antibody should be obtained within 1 to 2 months after completion of the 3rd dose of vaccine. This is mandatory. We need to know our vaccine status. In occupational setting, prophylactic doses of Hbig initiated within 1 week following percutaneous exposure to Hbsag positive blood provides an estimated 75% protection from Hbv infection. So if you go ahead with a prophylactic dose, if you feel that you have been exposed, right, and you know the status of your source, then it will give you a good protection of 75%. Right. So for HCV, we don't have a vaccine here. There is no PEP for exposure to hepatitis C. Baseline antibody titers and liver function tests should be done and then followed at 3 to 6 months. HCV RNA levels should be monitored periodically. And it is established that the risk of acquiring infection is very low. Approximately 50% of symptomatic patients clear the virus spontaneously. So infection rate is very low as you compare it with hepatitis B. Moreover, those who acquire infection have high rate of progression to chronic infection. This is also true. Clinical trials reflect that if hepatitis C infection is treated during the acute phase, which means that you are detecting HCV RNA levels, it is associated with high sustained virological response rate ranging from 75 to 100%. Right, so FDA has actually approved quantitative, qualitative NAT with detectable levels of 25 international unit per ml or lower should be used to detect HCV RNA with negative HCV antibody diagnosed within 6 months of exposure to hepatitis C virus. Treatment should be initiated within 12 weeks of exposure to effectively decrease the transmission and to prevent chronic HCV infection. The exposed person should be counseled for risk of infection, post-exposure illness reporting like fever, abdominal pain, jaundice after hepatitis B or C exposure, secondary spread, and PP compliance and regular follow-up has to be done to control both the disease HBV as well as HCV. These are the references from which I had prepared this PPT to my best of my knowledge. Thank you so much for attending, and any questions, feel free to ask.
Thank you so much, ma'am. Thank you so much, ma'am, for enlightening us with the knowledge. Next, we have Dr. Rahul Gelat,
Good afternoon, everyone. To proceed with I pledge, I request all the panelists to kindly switch on your camera, raise your right hand, and repeat after me. I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you, everyone. Over to Dr. Junam.
Thank you, sir. So, next, moving on to question answer session. Since
I got one question. How much gap is required between hepatitis B vaccine and COVID-19 vaccine?
We'll have Dr. Kanika to answer that question.
Yeah, so ma'am, regarding COVID vaccine and hepatitis B vaccine, ideally, like we say that COVID vaccine is in terms of like some schedule is being conducted in your hospital, and if you have 2 or 3 days for those, so I think COVID vaccine will get a priority over Hep B vaccine in the sense of the time limit that the institution is giving to you. But when we say taking 2 vaccines, so ideally we can keep a gap of 4 weeks, which is being said for every vaccine that we talk about. So 4 weeks can be the time, but if you have to, like hepatitis B clinic is there in your hospital and there is sort of a camp for COVID-19 vaccine. So taking the time of the conduct of camp in mind, you can go for COVID-19 vaccine first and then wait for 4 weeks and get the hepatitis B vaccine done in your hospital clinics.
And if any patient is already suffering from COVID-19, then during that period he can take the vaccine?
No, it is always recommended, like for COVID-19 doses also, as we are telling that we wait for 3 months after we recover from the current infection for COVID-19 booster or the next dose. So for hepatitis B vaccine, I think I'll have to go check this, but as of that, if we follow for hepatitis B, then we wait for the 3 months to pass and then take hepatitis B vaccine.
Thank you, ma'am.
We can have the question and answers now. Please requesting you all once again to drop in your questions in the question and answer panel. Okay, so we have few more questions. The question says, how long does HBV survive outside the body? How long does the hepatitis B virus survive outside the body? Dr. Kanika, would you like to take that?
So the hepatitis B virus can survive outside the body for at least 7 days, and during that time the virus is still capable of causing infection. And for hepatitis C, this period is 4 days.
Okay. Any further questions coming in from the audience? The other question that we see is, can hepatitis B positive mothers breastfeed their baby?
Given the critical role of breastfeeding and the fact that about 5% of mothers worldwide are chronic hepatitis B carriers, so examination of studies, literature review, that they indicate that there is no evidence that breastfeeding per se poses any additional risk to infants of hepatitis B virus carrier mothers. And the use of hepatitis B vaccine in infant immunization programs recommended by WHO is now being implemented in many countries. And it is a further development which will eventually eliminate the risk of transmission.
Thank you. I would request Dr. Shakil to answer the next query. How soon after exposure to hepatitis B will symptoms appear? What should be the post-exposure prophylaxis? I think we could emphasize more on the post-exposure prophylaxis, since you very immaculately covered that topic, ma'am.
Okay, so exposure to HBV symptoms, when we get, for example, HBV infection, the symptoms arises after 3 to 4 weeks of infection. Right, you know the hepatitis symptoms, like you may have yellowing of the skin or the liver is infected, and you may have a mild fever, vomiting, and loss of appetite, etc. Right, and by then you're doing your HBV level, you're checking the status of whether you've been Hbsag positive. That is what you need to do a screening. If you fear that you have been exposed or you have had a finger prick or you've been exposed to any kind of body fluid, then in that case you have to do a screening. Look for your Hbsag status. If it means that it is positive, then you have to go ahead. Before that itself, as I said, that within 24 hours of you getting exposed, you have to do the post-exposure prophylaxis.
Thank you so much, Dr. Shakil. I'm so sorry, Dr. Shakila. So very informative and very skillfully covered the query. Do we have any more queries coming from the participants? So I believe we have no further queries. And with your permission, I would request for the closing remarks.
Yeah, Dr. Junna?
Yes, ma'am. Thank you so much, ma'am. Lastly, now I would like to request Dr. Ruchi Pandey, Professor, Department of Periodontology, MRDC, to deliver the vote of thanks.
Today's webinar was very informative, and on behalf of Department of Periodontology, I would like to thank all the speakers for sharing their valuable knowledge and highlighting the various aspects of hepatitis B and C, like prevalence rate, estimated point prevalences, the types of hepatitis, the various vaccines which have been introduced in the market like monovalent and combination, rapid diagnostic kits, risk of Hbv infection in healthcare workers, safer medical devices, etc. I thank Institute of Liver and Biliary Sciences team, our principal, Dr. Arundeep Singh sir, our vice principal sir, and all the participants for making this webinar a huge success. I would just remind all the participants to kindly fill the post-webinar link, which has been shared in the chat box. Thank you all for participating.
Thank you so much, Dr. Junam, and special mention is required to Dr. Pooja Palwankar and Dr. Arundeep Singh. Dr. Palwankar has literally spent nights to make sure that everything is perfect to the T, and she personally herself was so much involved in getting everything in order. So I thank you, Dr. Pooja, for that, and we couldn't have done this without your help and support, ma'am.
Thank you, Dr. Namrata, for everything.
So, thank you so much, ma'am. Once again, I thank all the speakers, the presenters, Dr. Shakila Mahesh, Dr. Pooja Palwankar, Dr. Junam for very wonderfully conducting the whole webinar, Dr. Ruchi Pandey, and Dr. Kanika and Dr. Tushar from ILBS for giving a very engaging and a very interactive presentations. With your permission, ma'am, we will now be signing off. We'll be closing the webinar. The webinar link has been posted in your chat boxes. Requesting you all to once again, please click the post-webinar link. There are two links, the pre-webinar and the post-webinar. It is imperative that you submit the post-webinar link to get your e-certificates. Please be patient with us since the certificates might take about 3 days time to reach you in your email boxes, as we will send them with small slots. So bear with us, and thank you so much. We would love to hear from you for any improvements and your suggestions or any constructive criticisms that you might have for us. For that, drop in your emails to webinar.ilbs@gmail.com. Get connected to us with the Empathy Campaign at www.theempathycampaign. That's our website, and we would love to hear from you. Thank you so much. We are now signing off.
Yeah, Dr. Amrita, I would like to see you for the, we can meet again for the vaccination schedule to be set for our college.
We would definitely be very active in that regard, madam. Once we are finishing with the webinar schedule, that would be the next priority. Thank you.
Thank you so much.
Thank you, Dr. Pooja, for the wonderful session.
Thank you, Dr. Shakila.
So the webinar link would be open for some more minutes, and we are now signing off. Thank you.